Good morning. My name is James Lewis. I'm the Director of Professional Development for ITC, and today's topic is going to be anterior hip pain after a total hip. This is from a actual case that I had here recently, and while it was something that I've seen before, I thought it was pretty interesting, so I decided to bring it to your attention in grand rounds. And that's kind of how this works. Grand rounds is something that the topics come from you, they come from real life. And while I've got several of them that I can present to you, I want to know what you're seeing and then to celebrate those successes or discuss something that maybe didn't go quite as well as you wanted it to and how you handled that and what the ultimate outcome was. If you've got something you're interested in, just shoot me an email and I can discuss with you about how to get it going and how to get you online. All right, let's get started on our topic for today. Okay, there's a QR code here that you can download a document that'll kind of follow along and outline the case for you. But most of the or all of the information is on the slides here in front of you. So the patient is a 76-year-old female. She had completed her therapy. She initially had a plan of care of 14 sessions over 8 weeks and was now planning to return home to Florida after her last follow-up with her doctor in the upcoming day or so. Because she continued to have this intermittent groin pain with a catch sensation when she would be walking, particularly if it was unlevel surface or if she was getting up out of a chair. I decided to go ahead and kind of let the doctor in on what she was telling me. And again, this was something that she had said throughout her rehab. It was not in any way consistent or limiting what she could do. It was just something that she noticed, and she said on several occasions, it only happens occasionally. It's more of an annoyance, and it doesn't really keep me from doing anything. I just notice it. And so because she was going to the doctor, I went ahead and kind of preempted the doctor with an email and let him know that she was finished with therapy, but also coming to see him in the next day or so. So the email here, quick to the point. Basically, she's done quite well. She's had a few intermittent groin catches that she notices a couple of times. And then I've indicated that I felt this was something that I've experienced before, a relatively normal part of the rehab. I wanted to make sure you were aware because I did feel like she was going to bring it up in the visit. And then there's an ask. At the end of this email, I said, if you have any thoughts specifically on her or why some folks have more of this than others, is there something that might explain this catch? And so that's an ask of the doctor, hopefully prompting them to get back in touch with us. So is there anything that might explain the catch? Okay, while we waited for his response, we went ahead and kind of saw the patient on their last visit, did a little bit of a discharge reassessment. They would typically have over 10,000 steps per day. They were walking 3 different dogs because she was staying with her daughters here in the Dallas area. They had a couple of dogs and she would walk them. It was specifically triggered by an active hip flexion. If she was getting up out of a chair, if she was changing directions on unlevel ground, she would notice it intermittently. This was not something that, again, was not consistent. It would happen once during maybe a clinical session, during a visit, and then wouldn't happen again for a couple of hours, she would say. She wasn't able to really reproduce it when asked either. And so it made it quite difficult to really assess what was happening. although it was there as a normal part of her kind of day. She would feel it once or twice a day. At palpation, she was kind of tip on the anterior hip, right at kind of that psoas point. The clinical exam, after a couple of days, I went back into Athena and looked at clinical exam by the doctor. He noticed that she was also a little tender at the anterior hip. He noted that she was a bit able to perform a resisted leg raise, and that her symptoms appear to be reproducible with mechanical transition. So he was seeing a consistent pattern, but again, it was inconsistent in nature. He did go ahead and take x-rays. The notes showed that 2 views were taken, that it had a stable component alignment, slight offset, and then no loosening or no fracture noted. So in essence, a normal x-ray. At this point, if you were in the live session, I would stop and give you guys an opportunity to discuss. But you might take a moment here, stop the video, see if you can come up with anything that would explain this catching type of a problem on your own. And then when you're ready, start the video. We'll come back and we'll continue to discuss. Okay, so in most cases, let's say that we had, maybe our thoughts were maybe it's a tendinopathy of some kind. We would certainly kind of observe it. We might do a little activity modifications. We might see if the symptoms improve at that point. If not, we might send them for follow-up with the doctor. The doctor may decide, hey, I want to do an injection. And at that point, an injection would be not only for pain relief, but also as a diagnostic indicator or marker that if it relieved the symptoms, that was a pretty clear indicator that that was the problem. Longer term, most patients would respond to kind of a conservative treatment, although literature does suggest that some folks undergo, for more chronic problems, some folks do undergo what's tenotomy to relieve kind of that mechanical impingement piece. But what do you think about the offset, acetabular offset? Okay, the literature is becoming a little bit more aware of these kind of snaps, these anterior hip problems that people have after hip replacement. And essentially what they're finding is that it's mechanical irritation of the psoas tendon over the prosthesis. They notice that it's more common in kind of the metal to metal constructs as opposed to the dual construct, which would be like the metal to phenolic plastic prosthesis. It's about 5 to 18%, so it's not real common, but it is something that I've seen over the years a few different times. And it would really be something that I would kind of say would be of a more of a normal piece, because it didn't affect how we were able to go about the rehab. It was this annoyance, and it was something that people would say, I feel this, doesn't really hurt, doesn't really cause me problems. I just wanted to let you know about it. So it's one of those kinds of things. Okay, so what is acetabular offset? If you look at this image of the hip replacement, you'll see a green line that kind of follows along the pelvis, representing the edge of the bone, and where you would also like to see the acetabular cup oriented along that line. In orange there you see it pointing to the piece of the cup that has a slight offset relative to that green line. And that small piece there mechanically can impact the tissues in that area. More specifically, the psoas tendon and or any other muscles or tendons or just fascia that happens to kind of pop across that and would give somebody a catching sensation, albeit intermittently. Right? So essentially we had a normal looking x-ray, but the patient continued to feel something. Then that's where you would want to communicate with the physician. And because we did that, we got an answer back from the doctor that really kind of helped explain it a little bit more, in that the doctor said when they do their procedure, they try to reflect the joint capsule and then suture it back down. And in doing so, they leave sutures that are going to heal the capsule, but they're there, and sometimes those will cause a little bit of a pop or a catch. In addition to that, when they clean up the bone, they're making the cavity for the prosthesis to fit into. They do their best to smooth out those edges, but sometimes they're not completely smooth, and they'll have maybe a small little osteophyte or a small little piece of bone that is still there, what they might call a remnant, and that catches. So what I thought was a pretty nice detailed answer from the physician. And all because we decided that we would reach out and communicate with them. Otherwise, wouldn't have known that and wouldn't put that in my memory bank for the next time something like this occurs. So always good to talk with the physician about things. And it can be something that, maybe you've got an opportunity to shadow and you bring up something, hey, what are you looking at when you look at this x-ray? Can you help me understand what you're seeing, what you're looking at? And the doctor may kind of take a little bit of time and say, see that little piece right there? That's what might be causing our symptoms. And that's how I gained an ability to read x-rays, read MRIs, and really have a little bit better understanding of what I'm looking at there and how that presents or relates to me clinically. Okay, so we did review the literature for this a little bit. We looked at some conservative treatments, essentially talking about doing a little bit of stretching, possibly an injection, but all of those things really don't resolve the fact that there's still something there that's causing a mechanical irritation. So the next piece would be maybe an injection if it was actually painful and causing them trouble. We might get them back in to see the doctor, possibly doing a guided, image-guided injection. For those that are recalcitrant to that kind of treatment, they can do tenotomy. They can even do a revision on the acetabular cup to correct its position. Don't really think that that's worth going in for a revision. If you can go in and maybe do a little bit of a cleanup, kind of like they would on a fibrotic knee, where they just remove some scar tissue and so on, that might be all that's required from a surgical standpoint. I can't tell you that I've had one go back in for revision on something like this. It is typically something that they would just kind of live with because it's intermittent. Now, if it is consistent and painful and causing them functionality problems, then you might see that person go back in. Here's some of the literature that we looked at over the last 10 years. And if you wouldn't mind filling out a survey for me, just kind of gives me an opportunity to know, did you watch, what'd you think, and what we might do in the future as far as some additional content. So if you got any questions, you can send me an email. Otherwise, enjoy the rest of your afternoon. Bye-bye.